That's all right. If we only do one, we have 20 minutes. You want to go for it.
All right, so 72-year-old gentleman presented to Dr. Cohen's clinic, no visual complaints, medical history includes some minor GI issues, hypertension that's well controlled. He has had open heart surgery for a valve replacement and an appendectomy, prostate removal. For medications, he is on warfarin for his artificial heart valve, azathioprine, and multivitamins, some other medications. Visual acuity wise, he's 20/40 in the right eye and 20/32 in the left eye. So not too bad for a 72-year-old gentleman. And then IOP is within normal limits.
Oh, that's not cute. It's not gonna do anything. It's not gonna
Oh.
close the mouse.
We're
There's too many things here.
all right, Alex.
And we got a color fundus photo of the right eye. The material is clear. The nerve is pink, sharp and
Or
flat.
you can give them the mouse and you can point it. People will see it.
The vessels appear normal in caliber. My attention's drawn to, some hypopigmentation here. There looks to be an area of hemorrhage here. And there's some white hypopigmented spots kind of scattered throughout. You can see kind of the choroid underneath, but otherwise, that's all I got. I'm looking at this stuff and this stuff.
Yep, I agree.
This eye, same thing. I see these things. I don't know if that could just be regular macula, but it doesn't look like there's a hemorrhage in this eye, but I do see these little white deposits.
Good. I think that's it.
A little bit more cupping here, but healthy, right?
Agree. Okay, move on.
All right, this looks like an infrared image. You can see area.
Fluorescent, I think.
Oh, it's not okay.
So the nerve star.
Fundus autofluorescence. You can see mixed hypo and hyper autofluorescence, kind of mottled appearance over here. Macula looks to be pretty good. In that area, hemorrhage was like over here somewhere.
Oh, yeah, you can kind of see it.
How close to the
Oh, I
fovea?
can't see where it is, but I think I remember it was like somewhere over here.
How close to the fovea would you estimate kind of that area of concern was?
Like millimeter, 1.5 millimeters.
Okay, yeah.
Kind of the same thing here. We see, a little bit less hypo autofluorescence, but we do have this one big area of hyper autofluorescence. Okay, we've got an OCT of the right eye. The medial is pretty clear. We can see some intraretinal hyporeflectance, suspicious for like intraretinal fluid. And then we have some these are like subretinal deposits of hyperreflective material. We have some loss of the outer retina here with some hypertransmission. And then here we also have an area of hyperreflectance with an underlying area of a possible like pigment epithelial detachment with some hyporeflectance.
That's probably subretinal fluid there.
Yeah,
I think you're between the RP and the retina.
Oh, subretinal fluid, yeah. And these could be like intraretinal edema, or these could almost be like tubules or something. I can't really tell. I think it's edema.
Yeah.
And this eye, it looks pretty good. There's some of these hyper reflective deposits. But I don't see any intraretinal fluid here.
Which side of the RP are those on?
These look like they are on top of the RPE. Yeah, those are on top of the RPE.
So are those regular drusen or?
No, these look like pseudo drusen.
Yeah, there's probably pseudo drusen.
But
You
they're
guys
not
have been
like
good with
super
your-
reticular, but they look, All right, we got fluorescein angiogram of the right eye. And this is the early arterial phase, arterial phase. I see the arteries are lighting up. The veins have not lit up yet. And I don't see any activity here, any changes in the fluorescence there yet. I'm driving this thing now. All right, so we're going, we maybe see a hint of flush here in the vein. There, now we're in the luminal phase, the laminar phase, sorry. Maybe there's some increased fluorescence here, but I'm not not seeing a lot. Okay. The laminar phase. Maybe a little bit of increased fluorescence here. And now we're definitely seeing some increased fluorescence here. It's not expanding a lot, but it looks like it's expanding from what it was originally.
You can give it some time. And then as far as image acquisition, this may be too granular, but basically the way the fluorescents work is they go click, 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 if I get until it fills.
Mhm.
Once it fills, you can lock it. And then once you lock the images on the Heidelberg, it accumulates 100 images and gives you a better image.
Oh, wow. Okay.
So why you'll see is at a certain point, they'll jump and think, oh, that looks nicer.
Yeah,
So that's actually an optimized image.
yeah, this looks great.
Yeah, it looks nice. It's pretty.
So here you can see that it's,
Nice
foveal
image.
avascular zone. We see this along this vessel here. It appears to be an area of fluorescence that's increasing. This probably represents leakage here. I think there was an area of like hemorrhage here,
Very good.
which could be blocking hypofluorescence there.
Where is that? Pre-retinal, subretinal? Can you tell by the
The
vessel?
vessel's going over it,
Right.
so it's subretinal. We can see now these little punctate areas that we saw, these represented those hypopigmentated areas on the color photo. So these might actually be like drusen that are starting to stain.
Good.
And this continues to leak, this continues to block. But this actually looks pretty good. This is late. We can see all these little tiny areas here, likely staining from drusen.
So for leakage, you're following the border. So if you just scroll back and forward, you'll see the border of that clearly. I mean, this is a really nice leaky thing.
This is definitely leaking.
Yeah, so the border is.
This is about as good pooling an example as you're gonna get.
Yeah, but it pulls it. So leakage is leakage and then pooling is pooling into a fluid area. So.
Yeah,
The reason this stands out is
Yeah.
I think it's pre-RPE.
Yes, yeah, I think it's a
Is
type
it, what,
I think
I
chemical
can't
type.
remember. the
1, 2,
type.
and 3.
Yeah, I mean,
You have
I
that
can
in
never
your-
remember.
Type 1, 2, 3.
Yeah.
Kevin's got it.
but I think it started off as like a diagnosis based on like fluorescein or histology, and then now we're talking about, we can see it on the OCT, so it's, and then OCTA kind of threw a wrench in that.
Yes.
Okay.
Thanks.
All right. This eye. Okay, so we got, now we're going to the left eye. This is just a late. You can see a little bit of fluorescence there.
It's interesting. You can see two different drusen on that image, that next one. See the back. You see the dark ones on top, the little dark spots.
These little ones.
Yeah,
Yeah,
those are the
probably
those are the
reticular drusen, yeah.
So you can see the different ones. There's some reticular, some soft.
And this, I think, is staining. I think that's,
Yeah, probably bigger. That's that big bump you saw.
all right, we've got an ICG here. I tend to drawn to this. This looks kind of interesting here.
Is that nice looking?
This could be like a little,
That's a good one.
a little area of like irregular anastomosing blood vessels, maybe.
Mhm.
I don't know if I call it a polyp, but maybe. Yeah, this kind of looks like a polyp now.
So where would that come from? Where's the source of that vessel, that little complex? Can you see
So
that?
this, it seems to be coming off one of these retinal vessels.
Nah, it's subretinal. So
Well,
maybe.
this is subretinal.
Oh,
That's, that, it's his prejudice. He's already decided what it is. What Ophthalmology is, he has no idea where it's coming from,
Yeah.
but he knows because he's been indoctrinated that
Yeah.
this appearance is subretinal.
Right,
So this
but it
is a-
does look like it's coming off that.
This is a choroid.
Yeah.
If you couldn't see it before, this is just over top of it.
Right.
Because everything's
But-
lighted
but-
up.
But it
I'm
does
biased.
look like.
I'm
that,
very
yeah.
biased.
Yeah, it's two-dimensional.
Yeah. Okay. And this is a late ICG,
Yes.
so You see this area here, just suspicious, hyperfluorescent.
And your reticular pseudodrusen really jump out in late ICG, just
They do.
interestingly.
Let's see the other eye. I don't see anything that is concerning to me, really just normal choroidal looking vessels. There, you can see all this nice pseudodrusen now, there's little punctate ones. Okay. All right, and what do we have here? This looks like an OCT. We've got two different time points here.
Well, you can't see the bottom because it's cut off, but this was a former patient, so that's about
This is
2 years,
before.
yeah, a couple of years ago.
So
And
this
then,
is probably before they had exudation. They just had
Right.
some RPE changes. You were following them.
yeah,
And then all of a sudden you said, what's that?
Yeah.
And you saw some fluid there and you said, okay, I need to get an FA now. Okay, some kind of choroidal neovascularization. All right, and now we're following over time, the OCTs of the right eye. And we can see this when he just had some early pigment changes, especially here, this little area where it looks like the outer layers of the retina and the RPE had some pigment changes here. Looking kind of ratty here, but now you have some hypertransmission. And then now here you have thickening. Maybe a little early subretinal fluid there.
oh, and then something happens. Did we have to look at that later? Good,
Maybe you started treating him.
probably.
You probably treated him after this point.
Yeah.
I think they're getting better here. It looks like I see green here, so it's thinner here.
Okay, good.
Okay, yeah, I'll give it back to you.
Okay, so yeah, you basically hit on all the high points here. 72-year-old, he's not a smoker, no big visual complaints and vision. 20/40 in the right eye, 20/32 in the left eye. DFE, it showed that kind of concerning area of neovascularization or intraretinal theme. Left eye was largely unremarkable except for trace drusen. I thought it was an IR photo, but I guess it was autofluorescence. So it showed that dark hyperreflective spot in the macula surrounded by kind of like a ring-like hyperreflective area. And again, that correlated to that area on this photo concerning for neovascularization. The OCT, it showed trace drusen, it showed choroidal neovascular membrane in the subretinal space with some trace subretinal fluid. Left eye, there was no intraretinal fluid like you pointed out, but maybe some pseudodrusen or drusen changes. And then FA, the characteristic pattern there, there's like an early intense hyperfluorescence with a well-defined lacy appearance at first that progressively leads to kind of blur those borders. So I think you probably know the diagnosis. What's
On that, yeah, I mean, on the top of my
Yeah.
differential, we always include exudative macular degeneration. In this case of polypoidal chorioretinopathy.
Choroidal vascular.
Vasculopathy. Any other things that can cause choroidal neovascularization like chronic central serous?
So anything that can cause a pigment spot in the back of the eye.
Yeah.
Can cause a neovascular membrane. So you can just like
Pigment dystrophies.
anything. Like choroidal folds,
Mhm.
trauma, myopia,
Previous laser.
anything that causes anything in the RPA can cause a neovascular membrane.
Yes, I got this off like the AAO.
And they could be
PowerPoints.
idiopathic too, so I
Yes,
mean,
yeah,
I mean, statistically, none of these are proven, but they're by common agreement.
So yeah, I think we mentioned all of these. I think the second most common is pathologic myopia. But this patient ended up having wet AMD in the right eye with choroidal neovascularization. And would you say that was like within the fovea or extrafoveal neovascularization?
Extrafoveal.
Yeah, yeah. So he had extrafoveal choroidal neovascularization, and that's defined as greater than 200 microns from the fovea. So obviously we know about AMD, so I'll be brief. really important to know about though, because it's one of the leading causes of irreversible vision loss worldwide. It affects over 2 million people in the United States. I feel like most of them come through the VA clinic for us. Conventionally, it can be broken down into its dry and wet form. The dry form is defined by drusen and RPE changes, as well as geographic atrophy in its later stages. And then wet, obviously, you have your neovascularization with fluid accumulation, which accounts for about 10% of cases. So your main risk factors are age. We can't do much about that. Race, it's actually more prevalent in Caucasians. Family history is an important risk factor. I think there's a 3-fold increase if you have a first degree relative with AMD. Smoking is the #1 modifiable risk factor. So important to counsel your patients on smoking cessation. And then some minor risk factors include hypertension, cardiovascular disease, diet high in fats and low in antioxidants. That's why we treat patients with kind of micronutrients that are antioxidant effect. And then aspirin is another minor risk. And then with family history, I think there's like over 50 genes that play a contributing role. The main ones are your complement factor H and ARMS2 gene. And then it can also be classified based on its stage of the disease. So actually, like small little drusen is just a normal part of aging. Once they get larger than 63 microns, do you consider a patient to have early AMD? And once they're larger than 125 microns and they have pigmentary changes, are they categorized into the intermediate stage? And then your late stage of AMD is defined by geographic atrophy and neovascular. So obviously with exudative, you have the presence of some sort of macular neovascularization. Our patient, he was still 20/40 in his right eye, so it wasn't affecting the fovea too much. There wasn't a significant amount of fluid accumulation, but vision loss can progress very quickly in these patients. So they can have an acute drop in their central visual acuity, metamorphopsias, and paracentral scotomas. Just some things that you can notice on your exam. You can have sub and intraretinal fluid, exudates, hemorrhages. There can be a pigmented ring or a gray-green membrane. I think that's what Saba was getting at in one of the previous cases. And then obviously elevation of the RPE. We see PEDs with the OCT scans, and then a CFAN pattern of the subretinal vessels representing that neovascularization, those wispy vessels. And then the pathophysiology is pretty complex. We don't really have a exact understanding, but it essentially comes down to oxidative stress on the retina. It's multifactorial, so different environmental factors like smoking, genetic factors, and then obviously aging. This leads to chronic inflammation. It's thought to be mediated by complement factor H predominantly. And this chronic inflammation over time leads to the release of VEGF and neovascularization, and that's how you get your fluid. And then late stage, there's fibrosis. So this is kind of the main takeaway from this case is the different classifications of macular neovascularization. So this can be classified based on the location of the neovascularization, whether it's sub-RPE, subretinal, or within the retina. So, and they get its, the name was actually created because of its FA appearance, but this is so much easier to visualize on OCT, but I'll get into that. So type 1 arises from the choroid, erupts through Bruch's membrane, causes fluid between the RPE and Bruch's. It's the most common form, even though it's not called the classic. So that's kind of counterintuitive. But again, that's because of the FA. Type 2 is your classic choroidal neovascularization. It arises in the subretinal space, leading to fluid accumulation between the retina and the RPE. So that's what we had with our patient. And then type 3, you mentioned, Alex, this is your RAP, retinal angiomatosis proliferation. This is intraretinal in the deep capillary plexuses and kind of can go downward into the RPE and choroid. So this is how these kind of 3 classifications got their name based on FA appearance. So this is why it's called classic, because it has a more classic appearance with its with FA in its progression. So it's characterized by well demarcated areas of intense hyperfluorescence that appears early and progressively leaks. Early on, it has more of a lacy network pattern to it. And then as it progresses, it obviously obscures kind of the well demarcated boundaries. And then your occult, it's named occult because it's not well defined on FA. It doesn't have a classic characteristic pattern to it. So leakage can be early, but it can also occur late. The borders are generally more poorly defined, and it kind of has more of a stippled appearance to it. So our patient didn't really have this appearance on FA. Management, we know about, obviously you want to control risk factors. You can't do much about age, although I have heard Jeff Bezos, he just invested like $1 billion into an anti-aging like biotech company, which is pretty interesting. You want to
Constantly on to two.
So smoking, counseled them on smoking cessation. For your early AMD, your dry AMD, you put your patients on ARADS, Preservision. I'm at the VA right now, and we have a lot of patients with wet AMD who are still taking ARADS. And I feel like that's just because it's government funded, they don't have to pay for it, and there's kind of a placebo effect. I think if I were a patient, I would want to take it anyway. I'm curious, do you have your patients on
It's a
it?
tough one. The
As
studies, the ARED studies, none of them took into account whether they were being treated. So in the initial study where it was shown not to be beneficial, that predates the anti-VEGFs,
Mhm.
and it wasn't beneficial for late AMD, but that was a very old study. So we don't know now. Most people probably do it. The other thing that was not in the initial AREDs, but I think wasn't the recent, but I don't remember reading the result. You guys might, was zinc is not that good for your cognitive function. There's some evidence that zinc, so you get these old people where they're starting to fail and you have them on high dose zinc that might not be helping them. And that might be a bad idea. Have you heard that?
Yeah, I went, but then the issue was bladder issues, the whole zinc copper thing for a while, but the interesting thing is, having told you that zinc was supposed to have some value during the COVID crisis. So the question is, pick your poison.
Right.
So you got to figure out what's.
So it's true. It's not shown beneficial for preventing geographic atrophy progression. It's not shown beneficial for people with wet AMD. It does protect the fellow eye. So
That's
if
right.
you've got
That's
one
right.
eye, it's
Wet
like
and
a
dry.
50% reduction. That's a huge. So if anybody should take it, it's someone with wet in one eye and dry in the other. I think it was 40%, but I just say 50. So that's a huge, but yeah, AREDs. I'm old. I was hoping that ARED study would be negative when it first was done. I thought, gosh, it's finally we can stop with these stupid vitamins.
Well, that was the back on Newsom was the guy, right? Wasn't it?
Yeah,
Newsom?
down here. Newsom was down. He was
Right, so
saying this for a while.
they did it to shut him up, and he was right.
Yeah, it was positive. There's a long history, but go ahead. And we still don't know, but the other thing, fascinating thing is we still don't know why zinc helps. I don't think. We don't know why zinc helps the eye. Yeah, that's interesting.
And based on your comment on zinc, I think I saw that like different formulations have different concentrations of it. So I think they're experimenting with lower.
So the funny thing is, for me,
doses.
I just take lutein and zeaxanthin every day. That's it. I don't deal with all the other. If you look at if you really cut down on the AREDS trial and you look at the data, the vast majority of that effect is from the lutein component.
And then obviously your mainstay of treatment for wet AMD are your anti-VEGF agents. So Eylea, Lucentis, these are both FDA approved, and then Avastin, which is not FDA approved for wet AMD, but we use off-label because it's a lot cheaper for patients. And there's just different regimens in terms of how often you treat patients, and it kind of varies. You can do scheduled injections, as needed injections, and then the treat and extend model. I think this is just based on provider preference, how well the patient tolerates therapy, and obviously how aggressive the macular degeneration is.
Oh gosh, we're going over.
Pretty much
So,
everyone we see from the community that comes into our clinic is just every 4 weeks they get an injection.
No, not us, not our.
And
How
I
you
would-
guys.
I would update your slide.
Okay, there's 6 now.
I would update your slide. There's faricimab that was approved this year.
mhm.
That's anti-VEGF, anti-Ang2, which essentially is going to become one of the leaders of the market. So based on Tenaya on the CERN trials that are involved in that. And
So
brolucizumab, which nobody uses anymore.
So before we break, one little thing, which I think is of some importance, is, you know, that would not have been enrolled in any trial. So we don't know for sure that the treatments actually benefit this patient.
Because it's not subretinal.
It's not, it's also not vision loss, asymptomatic, non-subretinal, no vision loss. It's not, he wouldn't have gotten into any of the studies. So the question is, do the treatments actually help? And then the other thing is this a peripapillary, like at what point, I still have trouble with this. This one I treated, there's hemorrhage, it's pretty close to the fovea, but move it over to the right another like millimeter or 2. And I don't know, would you guys leave it? I mean, once I'm peripapillary membranes
Right.
this is kind of almost a it's,
Right, it's all based on the amount of blood.
yeah.
It's a blood to me. And the other issue is when you go back to your treatments for a minute.
Oh.
So especially in this lesion, there is, where is it?
That's the last one.
He just has to
Right,
treat it.
okay. So the other thing is that we don't do it very much anymore. There's something called photodynamic therapy. and
Yes, yeah.
PDT, and in this situation, it was the Everest 1 and Everest 2 trials that shows using a combination of anti-VEGF and PDT does help. I use PDT for central serous, and in rare cases, if you start with anti-VEGF and you're not getting anywhere, I don't know if you guys even have a PDT anymore, that they work very well combination in this.
Yeah, I probably do 5 or 10. You actually I have one of my best referring doctors at PDT. And he just wasn't going anywhere with Avastin and
Right.
Eylea and PDT, and he's been good for 6 months. And he follows his own OCTs and stuff.
It's supposed to help, especially with polyp form.
Right,
Right.
right, then that's what I look at.
Yeah. This is kind of.
We have one, but I've never seen anyone use it yet. But we do have the Visidine as well.
There you
Yeah,
go.
the Visitine's the hot item.
You mean at the university?
Yeah.
Yeah, but they used to have one at the VA, and then Nancy Kirk just decided to stop doing it. I don't know why.
So next week, we're